Thank you very much, Mr. Speaker, for the introduction.
Let me just say the title. It's non-enhancing, evaluation of brain tumors. Thank you. Please.
Thank you. Good afternoon, ladies and gentlemen. In this presentation, we will focus on the imaging after systemic therapies in the evaluation of brain tumors. In particular, we will focus in the evaluation of high-grade gliomas, because high-grade gliomas are the most common primary tumors in the brain. Standard therapy for high-grade gliomas includes maximal safe tumor resection, followed by radiotherapy and chemotherapy. And when we say safe, we mean that in the brain, as you know, there are some eloquent areas that shouldn't be affected by the surgical procedure. So we should resect as much tumor as possible without affecting this eloquent area. This is the meaning of maximal safe tumor resection. These tumors have some particularities that make them different to tumors in other locations. First, these tumors don't disseminate outside of the brain. It's very uncommon to find lymphadenopathies or metastases from a high-grade glioma, so we don't use the TNM classification. On the other hand, these tumors are very infiltrative. Tumor cells extend along the neural tracts, and it's quite impossible to resect all the tumor cells. So local recurrence is the rule for these tumors. Additionally, these tumors are very difficult to follow. The reasons for this difficulty are several. And one of them is that these tumors are very heterogeneous, and we can find areas of grade 2, grade 3, and grade 4 on histology into the same tumor, and different tumors can show different patterns of response to the same treatment. And even into the same tumor, we can find areas that respond different to the same treatment. And this is an example. Here you can see, here is a necrotic tumor, glioblastoma by biopsy. In the corpus callosum, there is an area of fine contrast enhancement. And after treatment with chemotherapy alone, in the follow-up in 81 and 160 days, we can find that this parietal occipital area shows response, while this other area in the corpus callosum shows progression. The same tumor, same treatment, different areas, different patterns of response. It's very difficult to give a global assessment of the response of a tumor that shows different patterns in different locations. There is a wide agreement that follow-up of these tumors must be done by MRI, and the clue for this follow-up and for this follow-up is to compare with previous studies. With MRI, as you know, there are a large variety of sequences and parameters, and this can be a problem also for this follow-up, because sometimes the actual examination and the previous one are not very comparable, are somewhat different, and this is also a difficulty for this follow-up. Additionally, we can find treatment-related inflammatory phenomena that can mimic or overlap the tumoral activity. So the recommendation to know what's happening to the tumor is to manage these tumors in multidisciplinary neuro-oncologic teams, including the neurosurgeon, the medical oncologist, the radiotherapist, the pathologist, and also the radiologist. And the radiologists must play a very relevant role in these multidisciplinary teams. Additionally, in these very heterogeneous tumors, we must be very homogeneous, and we must follow the consensus protocols of sequences and timing to be able to adapt each pattern of response to a known pattern. This is the protocol recommended for timing. We should do an MR exam in the early postoperative period, then 2 to 6 weeks after completing radiotherapy, and then every 2 to 4 months for 2 to 3 years, and then less frequently. In this session, we will divide the session in 3 parts, dealing with each one of these examinations: the early postoperative exam, the first exam after radiotherapy, and then the follow-up exams. Obviously, we must also do an MR exam when there was a clinical suspicion of progressive disease. So the first exam to be evaluated will be the early postoperative magnetic resonance, the EPMR study. And we must do this exam to evaluate the extent of resection. Different to what happened with other tumors, the pathologists cannot evaluate the extent of resection in brain tumors because an in-block resection of high-grade gliomas is not possible, and what the pathologist receives are small pieces of tumor. So he cannot evaluate the infiltration of the borders of the tumor. Additionally, we know that MRI is more sensitive than what we can call the neurosurgeon's intraoperative assessment to identify residual tumors. So it is the radiologist, the person who has to evaluate the extent of resection. And we know that the extent of resection is a prognostic factor in glioblastomas. In the graphic below, you can see the survival curve of patients with total resection in orange and patients with subtotal resection in blue. And additionally, this exam will be used as basal exam to evaluate the response to further treatments. When has to be done this early postoperative exam? This early postoperative exam has to be done into 72 hours post-surgery. This can be somewhat complicated to perform an MR exam to a patient that has been has resected a tumor 72 hours before, but this is the rule because of the diagnostic window concept. This concept was established by Albert in 1994, and according to this concept, no benign post-surgical enhancement should be found in an exam performed 72 hours into 72 hours of surgery. And this is the reason why we must do this exam into 72 hours, to be sure that all enhancements in this exam correspond to tumor. The protocol. To do this exam, we need at least T1 pre-contrast, T1 post-contrast, and diffusion-weighted images, at least. Let's see one example. This patient had a left frontal tumor here, and this is the EPMR exam, the post-operative exam. Here you can see that there is a large area of high-intensity signal. This is a T1 weighted post-contrast image. You can see that all the tumor is here. But this could be somewhat offensive to the neurosurgeon. The neurosurgeon has approached the tumor to obtain a complete resection. And we are saying that all this is tumor. This is not correct. We need a T1 pre-contrast image to evaluate enhancements. And if we have this T1 pre-contrast, we can see that here is an hyper-intense area in T1 pre-contrast that corresponds to hemostatic material. Not all this lesion is residual tumor. Just this small piece, this small medial piece, corresponds to tumor. This is a partial resection. We need to compare pre-contrast to post-contrast to be sure that what we are evaluating are contrast enhancements. We also need diffusion. And this is an example of why. Here you can see, this is the postoperative area, the cavity, post-surgical cavity. This is diffusion-weighted image. This is the ADC map. Here is an area of high-intensity signal in diffusion of restricted ADC. This corresponds to an infarct. In the next control, in 2 months, we find that here it's a small enhancing area. At this moment, this can be both. This can be progressive tumor, or this can be subacute infarct, subacute enhancing infarct. And at this moment, we can be sure of which one of these two options it's happening. But if we have this diffusion-weighted image, we can be sure that this is a subacute infarct because we know that here was an infarct. This is the reason why we need diffusion-weighted images in the EPMR exam. Okay, the next exam to be evaluated by will be the first exam after radiotherapy to be performed 2 to 6 weeks after completing radiotherapy. We need this exam to evaluate response to treatment because we are given a treatment to the patient with chemo and radiotherapy, and we need to know which is the result of the treatment that we are administering to the patient. And additionally, this exam can be used to define progressive disease on follow-up. If there is some kind of response and the size of the tumor is smaller, this is the exam that we have to use as basal to define progressive disease. The protocol that the experts suggest is to obtain sections not greater than 5 millimeters. We need to include T1 weighted, T2 weighted, and of flare, diffusion, and T1 weighted after contrast. And the experts recommend that we wait for up to 20 minutes after contrast administration to obtain a higher level of contrast enhancement. And in this period of time, you can perform diffusion, flare, or T2 weighted images. And the experts say that the advanced MR imaging techniques may help. Okay, we have this exam, and the aim of this exam is to evaluate the response. The recommendation is to follow the guidelines of the response assessment in neuro-oncology working group to do the evaluation of response. You can find this criteria in this nice paper of Journal of Clinical Oncology. And the first definition that the group makes is what must be measurable disease. A measurable disease must be a contrast-enhancing lesion, bidimensional, with clearly defined margins, with two perpendicular diameters of at least 10 millimeters each, and that was visible on 2 or more slices, as is the case in the figure you can see here. Some remarks. Measurable disease must be quantified as the product of the two maximal perpendicular diameters. What about multifocal tumors? When we find a multifocal tumor, this tumor must be quantified as the sum of the areas of a minimum of 2 and a maximum of 5 lesions. And when the tumor is around a cyst, the lesion must be considered non-measurable unless there was a nodular component measuring more than 10 millimeters, and the cystic or surgical cavity should not be measured in determining response. Let's see one example. This is a postoperative exam. Here is the post-surgical cavity. There are some nodules. How to measure this lesion? We must measure the two perpendicular diameters of each one of the lesions, like this. Diameter 1, diameter 2, to make the product. This is the product, and the addition of all the products is the value that we have to compare in the next follow-up exam. Again, the two perpendicular diameters of each one of the lesions, diameter 1, diameter 2, the product, and the addition of each one of the lesions. This is the value that we have to compare to establish response to the treatment. Tumors around a cyst, if the tumor it's not bidimensional, if there is not a diameter of more than 10 millimeters, must be considered as non-measurable. And if there are two diameters of more than 10 millimeters each, the lesion is measurable. But be aware, you just have to measure the enhancing lesion itself, not the cystic or post-surgical cavity, to evaluate response. With all these measurements, we have to evaluate response, and we have 4 possibilities: partial response, complete response, stable disease, or progression. To consider that we have a complete response, we need to fulfill all these criteria, and these criteria must be sustained for at least 4 weeks. We need a complete disappearance of enhancing lesions, with a stable or improved flare component, without new lesions, without corticosteroids, and the patient must be stable or improved clinically. All these criteria must be sustained for 4 weeks. If these criteria are not sustained for these 4 weeks, we must consider the lesion as the response of stable disease. For partial response, we need a more than 50% decrease in the enhancing lesion, with a stable or reduced doses of corticosteroid, and again, all the criteria must be fulfilled and must be sustained for at least 4 weeks. If not, this will be considered stable disease. And for progression, we just need to complete one of the criteria. We have enough with a more than 25 increase of the enhancing lesions, or a significant increase in the flare component, or a new lesion, any new lesion, or a definite deterioration of the patient. With any of these criteria, we can consider that there is a progression. If these criteria are not fulfilled, we should consider the response as a stable disease. But there is another possibility. There is a 5th possibility, what is the pseudoprogressive disease. Pseudoprogressive disease is a non-tumoral increase of the contrast enhancement. A more accurate definition will be an initial assessment of progression using standard criteria in the MRI examination done 1 to 3 months after radiotherapy, and when this target lesion stabilize or diminish in size upon continued therapy. And here we have an example. This is the EPMR exam of a patient that had a left temporal tumor, right temporal tumor. Here is the post-surgical cavity, T1 pre-contrast, T1 post-contrast. This is hemostatic material, but here is a small nodule. This is a partial resection. In the first exam post-radiotherapy, we can see that this nodule has significantly increased. Two options. This can be true progression, or this can be also pseudo-progression. To know if this is one or two or the other possibility, we have to wait, and in the next exam, this lesion has reduced in size with the same treatment. This was pseudo-progressive disease. Some remarks. The pathologic substrate is not clearly defined, but it seems that pronounced local tissue reaction with inflammatory component, edema, and abnormal vessel permeability should be involved. Advanced imaging with perfusion seems to offer advantage for the assessment of pseudoprogressive disease, and we must use this advanced technique to identify pseudoprogressive disease. But these techniques, we must be aware, because these techniques have not yet been evaluated on prospective trials. And currently, the only method for distinguishing between pseudoprogressive disease and true progression is to perform follow-up examinations. And this last is the most important remark or effect that derives, that appears because of the pseudoprogressive disease. Sorry. And is that the treatment, the chemotherapy, should be maintained in a speed of increase of tumor size in the first control after radiotherapy. If in the first control post-radiotherapy we find that the tumor increases in size, we must wait with the same treatment, because we can still have response to the treatment. And this is one example. This is an EPMR exam of a left frontal tumor resected. This is the T1 pre-contrast. This is hemostatic material, but here is a small nodule in the medial part of the resection. In 1 month after radiotherapy, we can see that the nodule has increased. Again, two possibilities: true progressive disease, pseudo-progressive disease. We must wait, we must follow with the same treatment, and in the next control, we see that this nodule has a partial response here and a complete response here. If we stop treatment here at this moment because we consider that this is true progressive disease, we will deny a still useful treatment to this patient. Another example, the EPMR exam, a small nodule in the parieto-occipital area. 1 month after radiotherapy, the tumor has increased in size. We must wait with the same treatment, and in the next control, there is a partial response and even a complete response of the tumor. The role of advanced imaging techniques in the identification of perfusion, of pseudoprogressive disease. The most useful technique is perfusion-weighted imaging, because we know that perfusion-weighted imaging provides information about capillary density and neoangiogenesis, and we know that progressive disease produces neoangiogenesis. So a high CVV value, a high perfusion value, will suggest progressive disease, while low CVV value will suggest pseudoprogressive disease. This is true, but again, we must be very cautious because the level of evidence is not high. One example. This is the first post-radiotherapy exam of one patient. This is a large lesion here. Perfusion values are significantly high, and the CVV value is 9.4. This was a true progressive disease, while in the case below, this is the case I have shown you before. This is small nodule. This is the perfusion map, low CVV value, 0.7. This was pseudoprogressive disease. This phenomenon has produced that criteria for determining progressive disease into 3 months of chemotherapy, that is when we can find pseudoprogressive disease, have changed and are different depending on if the change is into the radiation field or outside of the radiation field. As you know, radiation field includes 2 centimeters of the border of the lesion. Then, if in the next control after radiotherapy we find that the lesion has increased, but this increase is into the radiation field, we must be aware because we can be sure if this is true progressive disease or pseudo-progressive disease. Different happens if the lesion is outside of the radiation field. This new lesion is outside of the radiation field. We know that there is no pseudo-progressive disease if there is no radiotherapy, so this is progressive disease. In this first exam, we must know which is the radiation field to define if the lesion is progressive disease or it can be pseudo-progressive disease. Okay, and the last exam that we have to evaluate is the follow-up exams performed 2 to 4 months after radiotherapy for 2 to 3 years, and then less frequently. We need to do these exams to monitor response to the treatment. We are given still the treatment, and we need to monitor the response, and we also want an early identification of progressive disease, because if we identify progressive disease, we can offer the patient pre-surgery, radiation, or systemic therapy, including anti-angiogenic drugs, temozolomide, and so on. And in the next minutes, we will say some words about anti-angiogenic drugs. Anti-angiogenic drugs are drugs focused against angiogenesis. They produce a normalization of tumor vasculature and restoration of the blood-brain barrier. And like this, they produce a rapid and profound reduction in edema and enhancement without impressive radiographic change. But this change is produced as a direct effect of the drug over the vessels. We can be sure what's happening in the tumor. This effect is direct to the vessels, not to the tumor. These drugs have produced some changes in the pattern of progression. We can find patterns of progression in these patients that are somewhat different to patterns that we find with other drugs. We can find a more frequently, finely enhancing or non-enhancing tumor progression. We can find also with more commonly distant and diffuse recurrence, and we also can find another pseudo-phenomena. We can find the pseudo-phenomena of pseudo-response. One example, this is the post-surgical cavity here in this patient treated with bevacizumab. Here is a local recurrence with finely enhancing contrast, but there is also a distant recurrence here in the optical chiasm and also in the lateral, in the wall of the temporal horn. Distant recurrence more common than with other drugs. But we can also find this very uncommon pattern of progression, diffuse recurrence. This is an example. This here is a small nodule that was classified as progressive disease. We gave to the patient bevacizumab. Here was complete response, no more contrast-enhancing nodule. But in the next follow-up, we find this very uncommon pattern of progression with hyperintensity in flare in both thalami, internal capsule, external capsule. This is a very uncommon pattern of diffuse recurrence, more common with anti-angiogenic drugs. And again, we can find a pseudo-phenomena, the pseudo-response phenomena. If the pseudo-progression was a non-tumoral increase in contrast enhancement, this is the opposite. This is a non-tumoral decrease of contrast enhancement, a non-tumoral decrease of contrast enhancement. We can define as a non-tumoral decrease in enhancement after treatment with enlargement of non-enhancing portion of the lesion on tutu-weighted and flare sequences. And this is one example. T1 post-contrast in baseline, and in 1 month after treatment with bevacizumab, this small nodule in the temporal lobe has reduced, but if we look at the flare images of the same patient, here was a nodule, but that is slightly reduced, but the flare component has significantly increased. According to the Rano criteria, there is a significant increase in flare imaging. This is progressive disease, a pseudo-response pattern. And just to finalize, as a summary, to say that the evaluation of brain tumors requires the involvement of multidisciplinary teams, multidisciplinary neuro-oncology teams, in which the radiologists must play a very prominent role, that the radiological assessment is critical for management and follow-up, and that MRI has to be done in 3 times, into the 72 hours of surgery, then 2 to 6 weeks after completion of radiotherapy, and then every 2 to 4 months. That the radiologist needs to be aware of the existence of pseudo-progression and pseudo-response phenomena, these pseudo-phenomena. And finally, that we should follow the RANO guidelines to evaluate the response to treatment. And thank you very much for your attention.